Good afternoon, everyone. Thank you so much to the PA Foundation for inviting Alltrna. Jill, thank you. We're very excited to be here. I'm Nerissa Kreher. I'm the Chief Medical Officer at Alltrna. And just a little bit about my background, I'm a pediatric endocrinologist. I've spent about 20 years working in the area of rare disease drug development across a number of different therapeutic areas and a number of different therapeutic modalities. So Alltrna is a company that has actually been around since 2018. We're based in Cambridge, Massachusetts, and we're focused on developing a type of therapy that you may not have heard of, actually, called tRNA therapies. So we'll talk a lot about tRNA. Many of you have heard of mRNA, but tRNA is a different type of therapy, and I'll be explaining what that is today. But just to give you a little bit of information about our company, we are based in Cambridge, Massachusetts, which is close to the Boston area. As I said, we're founded in 2018. We have about 65 employees, of which most of them are scientists. So we have laboratory space where we do our own research. Our leadership team has expertise in tRNA biology. In fact, we have one of the preeminent tRNA biologists who came from MIT working at our company. We have expertise in oligonucleotide synthesis on the side of actually making the drug and rare disease drug development. It's also worth noting, if she were here to share with you today, our CEO, Michelle Werner, is the mother of a child with a rare disease called Duchenne muscular dystrophy. And so that passion for rare disease drug development is infused truly throughout our company through her leadership. So I know that many of you are very familiar with rare diseases. There are somewhere between 6 and 10, if not more, rare diseases. But there's still a lot of unmet need from the standpoint of only about 5% of all rare diseases have an approved therapy. So we all have a lot of work to do as companies, as physicians, clinicians, healthcare providers, patients, families, patient advocacy groups, working all together to try to find more treatments. At Alltrna, this tRNA approach that we are taking is a different approach than many therapies where we think about therapies being developed for a specific disease or a specific gene. So the gene therapies, the gene editing, mRNA, siRNA, oligonucleotide type therapies often are very specific to one disease at a time. But we are focusing actually on an approach that isn't a disease-by-disease approach, but instead it is a mutation-by-mutation approach. So I'll explain what that means as I go through the presentation today. But basically, the sort of summary will be, instead of thinking about only treating one patient population with a specific disease, we will be looking at a number of different diseases with people who share the same mutation that our drug can treat. So let's get a little bit more into that. A little bit of genetics to start. So we talk a lot of science. You've heard a lot of science today, lots of words. And also, I said to someone earlier, we use like 3 or 4 different words to explain the same thing, which can be very confusing. So mutations, there are different kinds of mutations. One is called nonsense mutations, which you can see here at the top. Another is called missense mutation. There are others called frame shift mutations. And the mutations that we're focused on currently at Alltrna are called nonsense mutations. Now, as I mentioned, there are lots of different names for the same thing, and so nonsense mutations may also be called stop codon mutations. I may use that term. They might also be called premature termination codons or mutations. I probably will use that term as well. But these are all one specific kind of mutation that our tRNA can help. I have a couple of videos to show just to go through a little bit about how our tRNA works. So the first video is actually the normal situation, what is happening within us right now as proteins are being made. So before I click the start, this, just to orient you, I think you can see my cursor here. This is the mRNA. So this is that part of the code that is telling the body what is the code to make the specific protein or the specific enzyme that we need for certain function. Going into something called the ribosome, which is the translational machinery inside of the cell. As I click the video, this is going to open up and you're going to see the tRNA, and the T stands for transfer. And then ultimately, you'll see here the protein being made. And so this is generic. This could be any protein that we're talking about. But, in the situation of PA, for example, the propionyl-CoA. So let's start the video. And again, you see the mRNA going into the ribosome. This will open up in just a moment. There we go. And these little blue molecules are the transfer RNAs. The transfer RNA sits on the mRNA, reads that, goes out into the cellular environment to find the right amino acid that should be in the protein chain, allowing that protein expression, that full-length protein to be made. Now, that's in the situation where everything is working as it's supposed to. In the situation where, sorry, I'm having an issue with advancing. In the situation where we have that premature termination codon, or again, using lots of terms to describe the same thing, stop codon or nonsense mutation, and that's indicated here in this sort of bright red or bright fuchsia color. This is a mutation. And so in this situation, what you will see is as that ribosome opens up and we see inside, there's actually no natural tRNA that can read this mutation. So it thinks that the protein is supposed to stop being made, and that protein then is not fully expressed, and we end up with disease. Now, this bright yellow color, this is one of our Alltrna engineered tRNAs, which is actually able to read that stop codon and say, okay, instead of actually stopping, I know this is supposed to be a certain amino acid. It goes out and finds it and adds it to the protein chain so that we have full protein expression. So in this situation, this is something that you may have heard a term called read-through therapy. That is what these tRNAs are doing. But I will say, for those of you in the room who know about some of the read-throughs that are older, they are not very specific, whereas our tRNAs are very specific and place the appropriate amino acid in the chain, not just any amino acid. So this begs the question of, okay, there are all these mutations that cause disease. I've told you about 10% of genetic diseases are caused by stop codon or nonsense mutations. And so with that, that means that of any one genetic population of disease, we'll use propionic acidemia as an example, about 10% of patients likely have a nonsense mutation. It actually turns out, that there are two main nonsense mutations that represent about 50% of all the nonsense mutations. So it turns out there are actually 19 of them total, but what's important here is that we really are focused on developing the therapy for this mutation and this second mutation because that takes care of about 50% of all the nonsense mutations. I'll talk a little bit about ARG to TGA mostly today because that is the first drug that we are developing. So this ARG to TGA, what does that mean? So what that means is that the mutation that's occurring is TGA. And this is something that for those of you who have had genetic testing done, a genetic counselor or your physician or healthcare provider will know what your mutation is. And so people that have this TGA stop mutation, it's actually supposed to be an arginine. And so this first therapy that I'll be talking a little bit about later, that is what we're fixing, this ARG to TGA. Now, we also have a program that's about a year behind the first program in development that is what we call GlenTag. And here, the mutation again is TAG, but the amino acid that's supposed to be there is glutamine. So there is something coming from that, but I won't be spending much time on that today. The middle panel just represents that over this 7 years that Alltrna has been around, we've been doing a lot of work with both cell models and animal models. I'm going to show some animal model data today, but a lot of work with different cell models, which we call in vitro, looking at more than 25 different genetic diseases where we have been able to show that in these cell models, we can generate full-length protein expression utilizing this tRNA approach. So that's some of that early proof of concept data that through the path of drug development we really have to have before we can move into human clinical trials. So as I mentioned at the beginning, we are not taking this disease by disease specific approach, but we're thinking about an approach that will allow us to potentially develop drugs that can help smaller and smaller patient populations, where clinical development may just not be feasible if we have such very, very small or sometimes called ultra-rare populations. So by thinking about pooling groups of patients with different diseases, but shared mutation, we have an opportunity where we may be able to develop a drug that's actually disease agnostic, but mutation specific. Again, allowing for more opportunity for patients to be treated with more and more rare disease. And this video just sort of is a depiction of that, where what you'll see is in the different different colors, these would represent different patient groups. And then across those, this sort of 10% or so of people with a shared mutation would have an opportunity to be treated with one of these tRNA therapies. Okay, so I'm going to move into some specific data. First, I'm going to talk about what AP003 is. So this is, again, our first development candidate. It is not yet in clinical trials. I think it's very important for us to be transparent as companies about where we are. So we are in the throes of animal studies that will ultimately allow us to, as was mentioned earlier, move into what we call IND, which is investigational new drug application that are submitted to the FDA and actually across different countries, similar type process that allow us to be reviewed for safety, importantly, and a review by an independent body that says you have the right amount of information that we believe should allow you to move into human clinical trials. So we're not there yet, but we are actively as a company working on getting there and hope to be able to share next year that we are moving into the clinic. So we feel like we're very close, but not there yet. So what is AP003? First of all, it's one of these transfer RNAs. The transfer RNAs are cloverleaf shaped. They read that genetic code that I showed you the video of and place that appropriate amino acid into the growing protein chain. Now, these tRNAs, if we were to put them in the blood by themselves, they wouldn't last very long. They get chewed up by something called proteases. So they have to be packaged in something to deliver them to a specific tissue. And in the case of AP003, we're packaging them in something called a lipid nanoparticle. So lipids are fats, and so they're basically, think of them as little fat globules that we're putting the tRNAs in, and then through an intravenous infusion, so an infusion through the vein, they are delivered into the bloodstream, and they end up going mainly to the liver, some other places, but the main area of interest for this audience is the liver. That's where a lot of these different proteins are made related to the inborn errors of metabolism. At the end of the talk, I'll talk about some other opportunities we have to move into other tissues, but for now, we'll stick with delivering to the liver. Now, this audience is well-versed in inborn errors of metabolism, of course, which propionic acidemia is one of many. You know that they are genetic diseases caused by missing enzymes or proteins. They interfere with the ability of the body to break down different fats, proteins, in the case of PA, carbohydrates, and those build-up products that happen then cause some of the toxicities that we see that cause the signs and symptoms of the various diseases. So for Alltrna and AP003, the focus being the inborn errors of metabolism, we will be looking at patient populations that include the organic acidemias, propionic acidemia, which is one of those, methylmalonic acidemia, which has come up a little bit in discussion today. And then there are other more rare ones. One would be isovaleric acidemia. In addition, phenylketonuria, which is another of the inborn errors, and then some of the urea cycle disorders as well, the most common being ornithine transcarbamylase deficiency, but there's a list of 6 or 7 that we're also studying. I think it's probably not my place to talk about propionic acidemia from the sort of clinical perspective. You've heard a lot of that today. Many of you know a lot of that already. So this is just a quick summary on PA. I won't spend much time there. So next, we're going to move into some of our data. I promise this and one more slide like it are the most complicated of all the slides, and we're not going to go into all the detail. This is really just meant to help show you about a couple of the mouse models that we've developed at Alltrna that help us understand how AP003 works. So the first mouse model is a methylmalonic acidemia model, which again, very similar but not the same as PA or propionic acidemia. And in this case, this mouse model actually has the human gene for M-mute, which is the appropriate protein needed for MMA, and it allows us to measure whether or not our drug can increase the appropriate expression of the protein that's needed in methylmalonic acidemia. And in fact, that is the case. So I'll walk you through. This is a single intravenous dose of AP003. We are doing studies, of course, where there are repeat doses. At this point in time, we believe the therapy will need to be dosed about every 2 weeks. There's an opportunity as we develop the drug that could be lengthened, but currently we're thinking about every 2 weeks. And so with the single dose, though, at day 4, we're able to measure, as you can see, about 38% of the normal protein that is needed. Now, importantly, in these diseases, we only need to correct a little bit of protein to see disease modification. And in fact, for many of the diseases, it's in the sort of 2, 3, 5% range that we need to correct. So this 38% we're seeing, we're very excited about because that's a very high level of protein expression. And again, this is the normal protein that's being expressed. Even out at day 14, you can see, so 2 weeks out, we still have about 10% protein restoration. So again, we're currently thinking that this is a medication that would need to be delivered in our clinical trials about every 2 weeks. Now, the next model that we have is a phenylketonuria, or PKU model. And PKU, many of you may know, similar inborn error of metabolism. In this situation, patients don't make a certain protein called PAH, and they have an elevation of something called phenylalanine. With this model, not only can we measure protein expression, like I showed you in the MMA model, but we can also measure what the protein does to phenylalanine. And so we call that a biomarker. You've heard that term today. And what you will see on the next slide is, or maybe 2 slides, is that we see not only protein expression, but we're able to show that that protein works because we're reducing the phenylalanine. So let's look at those data. So here first, I'm just showing you the protein expression, and again, that's called PAH. This is again one single dose of our medicine, AP003, measuring at about 72 hours or 3 days. We see about 7.5% protein expression. Now, many of you may say, well, wait, in that methylmalonic mouse, you said it was 38% at 4 days. So why is it only 7.5% at 3 days in this model? We believe that it's related to the fact that every protein has a different half-life or how long it sticks around. And this protein actually has a relatively short half-life. It doesn't stick around in the blood as long. And so we believe that this is an issue of not that we're not seeing that expression, we certainly are, it just goes away faster than it does in the methylmalonic model. So at 72 hours, again, 7.5% protein expression. As we speak with experts in inborn errors of metabolism and specifically PKU, they very much believe this is a clinically relevant and important amount of protein to be expressed. And as I mentioned, what we're really excited about is that this amount of protein expression, which you see represented here in the bar, it's just a different scale, that's 7.5% protein expression. We see about 80% biomarker reduction or phenylalanine reduction. Now, importantly, this is a model of classic PKU where the patients have very high phenylalanine levels. I'm sorry, not the patients, the mice have very high levels of phenylalanine, upwards of 1,200 micromole per liter, which is, again, in the classic range or the more severe range. So we're able to reduce this, again, to a level where if this were a patient, they may well be able to very much change their diet and the diet restriction that is required. So we're very excited about these mouse model data. Of course, importantly, we have to get into human clinical trials to prove that this, in fact, translates into humans. But thus far, we're seeing very encouraging results that we are excited about. So just in summary, putting that all together, we've shown mechanism of action through both cell models as well as mouse models. We know that we're getting to the site of action, the liver. I didn't show specific data, what we would call histopathology data, where we can actually measure the drug, we can measure the enzyme being made, but we do see it in the liver, spread throughout the liver, which is also important. And again, this potential for clinical benefit shown in the mouse model with the phenylalanine reduction. Safety is of critical importance in any drug development program, of course. So we have ongoing safety studies. What I can share now is that in all the animal models we've treated, we have not seen safety signals of concern. We've seen safety signals that would point to what one would anticipate and we know in the drug development space related to this lipid nanoparticle delivery approach. But this is an approach that's already been in humans, and so we know what to watch for and what to look for. We do have ongoing studies that are required for that IND process. So those are referred to as GLP. GLP stands for Good Laboratory Practice. It basically just means that there are lots of controls put in place around these studies. And so those studies are ongoing and are really sort of the gold standard for safety studies. Those are required as part of that IND package. Those are ongoing. And we've had lots of very encouraging conversations with regulatory bodies like the FDA in thinking about how we develop this type of drug. So I mentioned earlier that, not only are we excited about the approach with AP003, which is indicated on this top bar. So ultimately, our plan is to generate data in adults. This is another part of drug development. Before we move into children, typically, not always, but typically, regulatory agencies want to see some safety and efficacy data in adults before they allow us to move into what we would say is a more vulnerable population of pediatrics. So we will start in an adult population, but then we very rapidly want to move into what we would call a basket trial. So that basket trial would include multiple patients with inborn errors of metabolism, not just one group of patients, but like I mentioned earlier, PKU, for example, propionic acidemia, for example, methylmalonic acidemia, and some of the urea cycle disorders as well. So those groups of patients with that shared mutation, that ARG to TGA, that AP003 can help to treat. So with that basket trial approach, a single tRNA medicine across different diseases, we hope to be able to impact patients with those shared mutations. I do think it's important just to mention, as I sort of alluded to earlier, if we think about these tRNAs and different delivery mechanisms, so you heard something about a virus called AAV earlier, which is a way in which gene therapy is typically done. If we think about delivering tRNAs with an AAV, we may have an opportunity to reach other tissues, like the brain, for example. Thinking about other mechanisms, we might be able to get into muscle, where there are diseases like Duchenne muscular dystrophy. So a lot of opportunity with these tRNAs. Of course, again, today we're talking really about liver and AP003, but just to share some of our excitement about the sort of vast reach that the tRNAs may have. So I want to finish, and we have a video running in the back, and in talking with many of you, this may not need to be said, but it's a sort of public service announcement, if you will, for the importance of understanding your genetic mutation, or genotype, we would call it. And so the medicine that we're delivering, of course, we really need to understand the patient's genotype to understand if our medicine can help them. And so the push for genetic testing, which again, in conversations, many of you already have had genetic testing, and I'm really happy to hear that. And I think what we're seeing is that many physicians are incorporating this now into their day-to-day practice, but that doesn't mean that's always been the case. So we do have opportunities to help people with genetic testing. the sort of QR code here, and what we have at the back is a partnership we did with NORD, which is an organization for rare disease, where we're talking to people about genetic testing. So if you have any questions about that, I'm happy to try to answer them. Also something you can talk with your physician about. And again, if you're interested in the specifics of your mutation and really understanding it, your physician or the genetic counselor in your clinic will be able to help with that as well. So to summarize, our development candidate is AP003. We are advancing that and hope to be in the clinic sometime next year. Again, we will be first focused on adult, but then as quickly as we can, moving into the pediatric population, multiple inborn errors of metabolism. We have coined this term stop codon disease to really represent patients with those shared mutations. And obviously with propionic acidemia, this is a patient population that we are interested in learning more about, learning with you, incorporating those learnings into ultimate clinical trials, which is very important to us as a company. And I look forward to answering any questions and continuing to get to know this community better. Thank you. So just to repeat the question, how important is nonsense-mediated decay? That's a term I'll try to explain. And then would we need a companion diagnostic related to that? So nonsense-mediated decay, when you ask about that, are you asking about it from the standpoint of a safety perspective or from...
I mean, just in many cases, the RNA, when you have a stop codon, it gets degraded, right? It's a quality control process in the cell. So if you, and that's your substrate, that RNA. So if that RNA doesn't exist, then the drug wouldn't work.
That's
so
right.
I'm trying to see if that affects the development of the drug. I could imagine that there would be cases in which that is not a factor because for some reason the RNA is more stable. But then in some cases, you may lose it. And that's why I'm thinking, if one doesn't know if the RNA is there, would you have to develop a companion diagnostic to say, okay, this person will respond because the RNA is there?
Right. So in fact, we do not believe we need a companion diagnostic, but in fact, the mRNA, where the mutation is, the way we know that the mutation is there is through the patient's genetic testing, right? So if we know that, then we know that our AP003 will sit on that, the tRNA will sit on that mutation, if you will, and correct it. I mean, this is not gene editing, so correcting is not exactly the right term, but it will basically say, here's this mutation, I know it's the mutation, but I know that an arginine is supposed to be there, and I'm going to go and find an arginine and add it to the protein. So in fact, our tRNA therapy will keep that nonsense-mediated decay from occurring because we're making that full-length protein. Does that help answer the question? Okay. Yeah. Yes.
Just to clarify further, is that because the NMD processes are having post-ribosomal translation of the mRNA? Because if it's happening before it gets to the ribosome, then it seems like the tRNA wouldn't have a chance to have an effect.
So I think what you're referring to is in the video, it looks like the premature termination codon, the little fuchsia color, is before the ribosome. Is that what you're...
I'm saying it's in the mRNA before it gets to the ribosome.
So this tRNA is happening at the level of the ribosome, right, as the mRNA is being read. So our video, for the scientists in the room, may not be 100% accurate, right, because really what we could show is that the mRNA has the premature termination codon in it. The ribosome actually is coming and sitting on it. So it's actually happening at the level of the ribosome because that's where the tRNAs are. So it's,
Okay, thank you.
the video is maybe a little, we're taking a little bit of scientific, whatever you call that. I don't know. I can't think of the word, but yes.
Some protein can last longer, and the other proteins, after 3 days, you only get an expression of the 7%, but some other protein you can get like 38%, even after 2 weeks. So I'm just curious about like this enzyme in PA, propionic acidemia, propionic carboxylase, how that like protein, like what's the turnover this protein?
So great question. The question was about, I made a distinction between the half-life of the protein in PKU and the half-life in MMA. That is a great question, and this is why we need all of the researchers in the room and all of the research grants and all of the work being done, because we don't actually know all of these answers. We believe, based on limited literature out there, that the enzyme half-life is similar to what we see with immute in MMA. We do, because PKU is more common than the other inborn errors, we do know and feel pretty confident that the half-life of PAH is one of the shorter ones, and that's why we actually developed this mouse model in PKU, because we wanted to prove to ourselves, and sort of, if you think about it, like the highest bar of the shortest half-life protein, that we could still restore protein in PKU. So again, limited data, and I wish that I could point to a reference of the half-life of all of these different enzymes. And if anyone knows it, I would welcome a conversation around that. But we do believe that the PAH protein is the shortest of the half-lives. And again, sort of the higher test for us of whether we could restore it in a way that is meaningful.
I had a question for you. It's very exciting what you're working on. Congratulations. I work on MMA, and I work on mouse models and patients. So I had a few questions. One is about the clinical trial design. So are you suggesting that for your AP003, you're going to need to identify a patient that has that specific amenable mutation with MMA and or PA? So, you know, you're going to be going after a very rare patient, because in MMA, there's really no common stop codon mutations. There's recurrent mutations, but there's hundreds of mutations. So what, could you speak to that? Then the other question is about a mouse model, which is the following. Stop codon mutations in patients tend to be very severe. And in fact, what you're trying to do is convert a null into, a read-through. And MMA mice, when they are missing the gene, loss of function, have immediate neonatal lethality. So with your mice, if you were treating them at an older age or something like that, it suggests that you're getting physiologic read-through independent of your agent to keep the mouse alive, because otherwise it would have no chance of living past day of life 2.
Couple of things.
So maybe you could say one, then the second. It might,
Yes.
the last one's very detailed.
Okay, all right. So the first question was about the mutation, and this is a great point, and I may not have been 100% clear. So the mutation, as you mentioned, it is any ARG to TGA stop throughout the protein chain, so or through the mRNA, excuse me. So for example, in PKU, we know that there are about 7 common stop codons that are ARG to TGA spread throughout the gene. And this is actually one of the beauties of the tRNA, is that no matter where it is in the gene, where the mutation is in the gene, if it's an ARG to TGA stop, our tRNA can treat it. So it doesn't have to be one specific mutation, but any ARG to TGA mutation throughout the gene. And that would apply to MMA, PA, all of those.
Yeah, more specifically to MMA, we happen to have a specific interest in this for other reasons. There's not many stop codons, and I don't know how frequent that one is.
Yeah.
Can you say? Have you analyzed it?
Yeah, so this is another great question, and this is why the genotyping piece is so important. In PKU, there is a repository called BioPKU. It's like 17,000 PKU patients, and we were able to mine that and actually find the specific. There are 7% of PKU patients that have an ARG to TGA stop that are compound heterozygote or homozygote. We don't know that specific answer for all the other diseases. We've done very, very in-depth literature reviews. It turns out for MMA, for example, there's an Indian population where 25% of the patients have a stop. But then, as we all know, with founder effects and such, different patient populations within any one disease may have more or less of these mutations. Across all genetic disease, it's about 10%. So we do see, for example, Rett syndrome. 25% of girls with Rett have an ARG to TGA stop. So that's very much higher than that 10%, generally speaking. But what we're finding across all the inborn errors where we can find literature is that it does end up hovering somewhere in that 10% plus or minus, so like PKU 7%. But what we are undertaking, and again, I'm open to having conversations with anyone with genetic data and repositories. But for example, at Emory, we're doing a database search to really try to characterize this and importantly publish it to help get it out in the literature. Yeah. Okay, now I've forgotten your next
The second
question.
one was very, very technical about
The mouse
stop
model.
codon mutations in a mouse.
Yes.
Produce immediate lethality. So did you treat neonates or did you wait to weaning?
Yeah,
Or
yeah.
what happened with the mice?
So importantly, that MMA model is actually not a disease model. So it's not a lethal model. So that is an engineered model with the human immute protein. So it's not the sort of typical MMA model that's out there. It's an engineered model because we have to build these models with the specific stop.
Transgenic knockout. So what you do
Exactly.
is you make a null and you bring the transgene in trans.
Exactly.
But in that combination of an animal, in other words, a knockout transgenic, that's going to be an MMA mouse. That's the one that you want to treat. Is that the mouse you treated, or did you treat just the carrier with the transgene?
No, it is the actual carrier, the mouse with the gene, but that's why we can measure only the immute protein because it's human and not the biomarker.
Yeah, I'll talk to you
we can-
after
okay.
the talk. I think there's some confusion.
But our models have to be engineered specific because of the specific mutation for us to be able to test AP003.
Any more questions? No? Okay, so
Thank you.
thank you.